And it gives me pleasure this evening to welcome our next keynote address. So we've heard about roots, apple trees, and more. And our next speaker, Dr. Ana Lacerda, needs no introduction. A nice vitae, if you will. But one of the things that stood out to me was reading that as a pediatric resident at NYU, she took the time to pay attention to the condition of children with chronic conditions, and in particular, subsequently in her fellowship in oncology, and has carried the torch forward ever since, reminding us of the import, in a very recent paper, the import of diagnosis, day one, palliative care as part of the day one talk. From the point of diagnosis forward, even in such, at times, grievous conditions that our oncologists deal with. So I'm happy to announce this next keynote address, The Present Day, and introduce Dr. Lacerda.
Thank you. Well, thank you so much. It's a pleasure to be here, and I for sure was not expecting for a referral to my past as a resident in pediatrics many, many years ago. But anyway. So, sorry. The problem with the technologies. Yep. God. So, I was invited to talk to you today about the present day of pediatric palliative care. And the present day is marked by the 10th anniversary of the WHO resolution that recommended to member states the strengthening of palliative care and incorporation into the healthcare systems. So where are we now in October 2024? And thank you again to the Maruzza Foundation for bringing us here again to this wonderful city. How are we doing? Well, we do know a few things about children with palliative care needs. We know that there are at least 20 million children, and this number is always increasing as awareness is rising, and also the needs are rising, and survival is increasing of these children. And we also know that most of them live in low and middle income countries, and that many of them, most of them, also suffer from non-oncological conditions. So I'm also an oncologist, as Joanne is, and it's usually, it starts with children with cancer, but it's much more than children with cancer. We also know that this distinction between different kinds of health-related suffering is increasingly irrelevant, also for reasons of planning and delivery of services. We know that, oh, I just noticed there's a screen there too. Okay. We also know that the number of children that have needs and that are not immediately dying is also rising, which brings us another dimension of care, which is a transition to adult services. But are we able to deliver, are we able to deliver this care that children and families need right now? Well, it seems that despite tremendous improvements in the past 12 plus years, that we are still not there, because in many countries we still don't have the services that children and families need. And we also know that even in high-income countries, when we start talking about specialist pediatric palliative care services, we're probably still not in what we want, which is the palliative state. So we still have a lot to do nowadays. Now, sorry, whoops. Okay. Now, several thinkers, including Oprah Winfrey, have said that the only constant in this world is change. So I don't know about you, but I think that change is happening at an alarmingly faster rate to me. So right now, pediatric palliative care is dealing with a lot of changes. And I'm not going to talk about each and one of them. I just want to leave here a special word to our friends and colleagues at the Palliative, which are doing a wonderful work with all the humanitarian crises going on in the past few years. So there are changes, and one of the things that is also changing is the definition of palliative care. What is palliative care? So we all know that it started as end-of-life care for people who are dying. But then in the past 15 years or so, it changed into something that some call supportive care, which is care that should be integrated since diagnosis, since day one, and care for children, in this case, that have a life-limiting or life-threatening condition. And now it seems to be changing into something that is called timely preventative care, which is care that's nothing more than the right care for the right patient at the right time. But another moving concept in palliative care is what is the best way to deliver palliative care? Sorry. And here too, we are struggling. We are struggling with how to integrate the different types of services that we have available, inpatient and outpatient, and also nowadays the dual possibility of in-person and virtual care. How do we integrate technology? Oh, thank you so much. Thank you. Oh, 2 waters. Okay, wonderful. Magnificent. Thank you so much. So what we are looking to deliver is really the right care for the right patient at the right time, wherever that patient is, and at any time that the patient needs that care. And we are also all very aware of the 3 different levels of care that are recommended. So I'm not going to dwell here. But I think that what we are still struggling here are two things. One is what is the exact role of the so-called core or generalist teams, and how to integrate the specialist pediatric palliative care services with the disease-specific teams, which so often still have a sense of ownership of the patient and still question the added value of the specialist palliative care team. So I think that here we still have much to do. So all these changes actually really represent challenges, as we know. And these challenges are restrained by different factors that we all are experiencing worldwide. So how do we detangle these? How do we address all these challenges that pediatric palliative care is facing today? I believe that the key to the future of pediatric palliative care lies in 4 different aspects that are present today in this room, in this Congress, and that they are interconnected, of course. So we are talking about collaboration at a national and international level, education and training, and Joanne has already spoke about a lot about all the different ideas and events going on internationally. We are talking about integration, and especially integration since diagnosis, and really how to best deliver care. And I'm very happy to say that the WHO pathway for children in cancer does incorporate palliative care into the strategy. Also, increasing patient and public involvement and engagement, the nothing about me without me. So really children and young people and their families have a lot to do to tell us what they need. And really, again, collaboration. We really do need a lot of collaboration, but it pays off. So I'm not going to talk about all the collaboration because it would be an impossible task, a very full slide. So I'm just going to mention a few, and of course the first has to be the Maruzza Foundation. And just as an example, and I ask you to please photograph this slide and collaborate and fill in the survey for this, this project that is going on right now in the European Union. It's a project that's led by the team at the Sant Joan de Déu Hospital in Barcelona, and it aims to find which is the right care for children with palliative care needs in Europe. So collaborate and fill in the survey. So I believe that to keep on detangling these challenges, we need to learn how to best sell palliative care, how to make an attractive product out of it. So we have to move past this love-hate relationship that society has with palliative care in general, but still also with pediatric palliative care, which leads to this self-fulfilling prophecy, which is something that I learned from our colleague David Hui, who is an oncologist, not pediatric. He's a palliative oncologist in the United States. So this self-fulfilling prophecy is fueled by this stigma of palliative care as end-of-life care. So people are referred late, and so we don't deliver what we need to do. So we need to change this into a positive feedback cycle. We need to be able to demonstrate the benefits that we bring to our children and families. And by doing so, we will be increasingly able to deliver better care. So it seems nowadays that what we need are some tips. What we need to deliver is timely care, interdisciplinary care, personalized care, and care that is adapted to the person's settings. So wherever that person wishes to be, can be, and however she wants the care to be delivered. And to do that, we do need to engage with our community. We need to find simple, sometimes very visual, as in these examples, very visual language to really engage the community, the public, but also our colleagues, healthcare professionals, who are late adopters of palliative care and of pediatric palliative care. We need to continue to provide tools, learning tools, advocacy tools, research tools to all internationally. Okay, stopped working. Okay. And we also need to engage more with the arts. I bring here this example of a pediatric hospice that just opened the past summer in Bologna here in Italy, which is a collaboration with the architect Renzo Piano, who is a prize winner. And so this is a place that was designed with the families and with a wonderful architect, a place of healing and a place of reconnection. So we increasingly need this. We need also to learn how to integrate, how to intercalate probably in-person care with virtual care. And there are already recommendations out there on how to use technology with children and young people. So I do believe that what we are doing today, the teamwork that we are having right now in this international collaboration is paying off. We are really moving forward, and we are achieving things. We are getting there. And I cannot conclude without saying a word, inspired, of course, by this beautiful city of Rome, that despite everything, we still need connections. We need to forge relationships. We need to have this human touch that is nowadays threatened to be substituted by a mechanical touch, which I really hope it will not be the case. So maybe this is the ultimate challenge for all of us. How will we integrate technology, and we will talk about this in the next days, how will we integrate technology into delivery of pediatric palliative care? So in the end, I believe that we mustn't forget who we are, and that healthcare is both science and art. And as Joanne already pointed out, we are here to deliver and to address what Cicely Saunders so aptly called total pain. That's what we are here to do. We are healers as much as doctors. So I'm sure that the next 3 days here in Rome at this wonderful Congress will bring a lot of new horizons, and we will continue to learn from each other and maybe deepen our roots while enlarging our horizons. Thank you so much.